It's about time. Okay. Well, thank you all so much for joining us. Really excited for this session. We'll get through the afternoon slump and get energized again. So I'm going to have everyone just start by a brief introduction, about 20 seconds or less, with your name and title. So Deborah, I'll start with you.
Good afternoon, everybody. I'm Debbie Katz. I'm a board-certified child and adolescent psychiatrist, and I'm a senior national medical director at Optum.
Good afternoon, Manny Ariso, and I am the Chief Network Officer at Carillon Behavioral Health. I'm also the President of the Employer Division.
Good afternoon. My name is James Gilson. I'm with HCSC, specifically Blue Cross Blue Shield of New Mexico. I run care coordination, and that includes peer support programs.
And I am Helena Plater-Zyberk. I'm the founder and CEO of a digital peer-to-peer support network called Supportive.
Thank you all so much. So we're talking all things peer support today. So I kind of want to center us first and talk about something that the U.S. Surgeon General said about peer support specifically. He said, one thing we've dramatically underused as a country is the power of peer support. It can provide immense support to people before they're in full-blown crisis. It's critical when we think about how we can get people help when symptoms are still mild. So, Helena, I sort of want to start with you for this question. When we think of, maybe traditional peer support, some people might think of, groups specifically dealing with grief, addiction, or certain specific health conditions. But now peer support is broadening thanks to the digital landscape and rising awareness on mental health care for more people. So I would love for you to sort of center us on how you would define the peer support systems of today and how they've evolved from maybe those prior.
Sure, big question. Okay. Well, I think, one of the takeaways from a conference like this is that there is a place for almost every kind of modality through which, services are delivered in today's day and age. And when we conceived of Supportive, we definitely took inspiration from kind of the best of different types of peer support that are out there. So, we can all have those mental pictures of what happens during an Alcoholics Anonymous meeting and the power of bringing together people who have a shared experience, or a grief support group, for example, or a divorce support group. And then on the other end of the spectrum, peer support can still encompass, one-on-one conversations between someone in substance abuse recovery or alcohol recovery. And there are even like specialized reimbursable services for care navigation through peer support. So all of those things I think are on the table today for topics that we're going to discuss. And the piece of the puzzle that I bring to the table is, how do you infuse these models with technology and make them scalable to population level across every conceivable topic of mental, emotional, and social support that humans need in today's world.
Yeah, thank you for that. And I given Helena's explanation, just a sense of the audience, how many people are sort of seeing more information, noise, maybe around social media or online about other types of peer support? A few? Okay, interesting. So James, you have talked a lot about the, quote, power of the peer. We've heard it also from the Surgeon General recently and more so online. You serve a team of about 40 care coordinators and peer support workers. So can you talk a little bit about what that power is and how peer support is uniquely situated as a tool compared to maybe more traditional models like therapy or coaching?
How much time do I have? Because I can talk about this for hours. All right, so a couple of things. And first I'm going to start off with I think it's a little bit of a disservice to say that peers are going to be focused on kind of subacute function and experiences, right? Because my folks don't do that. I have a team that focuses specifically on members who are at the highest level of crisis. We go visit people in the ER, and that's what they do, and we show really good success with that. Because when a person's at the lowest point of the low, that's when they walk into an AA meeting, right? That's kind of the original peer support paradigm. That's when a person is ready to make a change, and having somebody walk into that room who has the lived experience and who has the ability to say, hey, I've been literally sitting in that chair where you are right now, and I'm not there anymore, right? I found a pathway out. I can help you find your pathway out. That's the superpower of the peer, is they walk in with instant street cred, right? If I walk into an emergency room to see somebody who is in crisis looking like this, they are totally going to diss me, right? Because I'm not believable, I'm not real, I'm a suit. But if I walk in normal, everyday human clothes, right, looking like I've been through hell and back because I have that street cred, right? That was driven home to me when I worked for the VA. This was many years ago. At the time, my beard was down to about here, and my hair to match. And I've had the high forehead since I was in high school, to the point where my first girlfriend, everybody thought I was her dad. And so here I am at 24 years old, working at the VA Medical Center, and all the non-vets thought I was one of them. I had instant street cred. That's one of the powers of the peer, right? Is the doorway opens for them. It's like an automatic door opener. The second thing is they have the lived experience, right? And so they can immediately relate to whatever this person has going on at whatever level that person is, right? I mean, back in the day, if you walked into an AA meeting wearing a watch, they threw you out because you weren't at bottom yet. You still had stuff to lose, right? Now we realize that people have like really high bottoms. Sometimes people can say enough's enough a lot sooner than losing everything. But the peer has already walked that path, and that's the real power of the peers, that they've walked the path. They are a merchant of hope. They are hope dealers.
Yeah. Manny, what can you respond to sort of that and your take on sort of, you mentioned the street cred and sort of the power of the peer. How does that fit into what you're working on?
I'll get it right by the end, I promise. Absolutely agree. One of the things that we have done through some of our Medicaid programs, specifically focused on individuals living with serious mental illness, is just that, right? It's bringing that hope around and having the opportunity through peer support. And it's not always like certified peer support specialists with this code, but it's how do we create systems and opportunities where, we can have that hope that James spoke about and start thinking about not behavioral health benefit management, but behavior change, right? How do we engage individuals living with SMI, individuals with mild or moderate conditions, but across the board. And by the way, we all need help somewhere. We are all peers. We are all a peer to someone, and someone can be a peer to us. So it's really unleashing the power of that in a way that really resonates and drives opportunity to not be okay and have somebody there for you. And so from a healthcare systematic approach is creating the incentives and making it easy to allow that to occur, because it is effective and it does bend, all the trend curves and all the things that we want to see change from an affordability perspective. So then how do we make sure that we make it easy to be able to do that?
Definitely. Thank you. Deborah, I'm going to come to you for this. The youth mental health crisis has been called the defining public health crisis of our time. So I'm curious if you can talk a little, and you've done a lot of extensive research on teens and adolescents. So can you talk a little bit about some of the misconceptions about what it is that, teens and young adults are actually looking for when it comes to their behavioral health care?
Sure. Is it on? Yes. I think that the misconception is that the model of traditional therapy and family work and seeing the pediatrician is going to work. We at Optum did ethnographic research that showed that adolescents don't want that. They want immediate response. I'm having this problem, help me, and I'm going to move on. So again, we at Optum have been very involved in a partnership with Supportive because what they're providing adolescents is anonymous, 24/7 access to peers in the moment, okay? And it's meeting them where they're at. And it's very interesting. Maybe I'll talk a little bit about it later. What we've noticed and what we've seen is the number one problem that they come with, which dovetails with the national problem of adults and teens, but teens even more, is loneliness. Okay? That's the first thing. I mean, what has happened in this country is loneliness is the epidemic, because everybody is like looking at in front of them at this little box, and they don't have the intimate kind of face-to-face, relationships they're developing. So the kind of peers services that can be provided, and a lot of kids don't want to self-identify. They don't want, because they're so concerned about peer pressure and what are they going to think about me. And one of the nice things about this peer model is it's anonymous, and you can present yourself in the way and get immediate response. And it's a model that we've already seen make a difference in the lives of these kids. And many of the adolescents come once, they leave, but you know what? A month later, they have another problem, and they'll join another chat. So, I mean, it's really about meeting and matching the individual, the developmental stage of the individual, the socioeconomic, the cultural, where they're at, meeting them in the schools, meeting them in the after-school programs. It's about what their needs are, and not how they can fit into our square box, but how we can fit into theirs.
Yeah, it's a really interesting point about not necessarily this long continuum, but even in short bursts that could be really helpful. I think going off of that, I'm curious, how do you ensure that you're pairing people, and anyone could also jump in on this as well, but I'll start with you, Deborah. How are you ensuring that you're pairing people with the right person at the right time for the right experience?
Well, just to understand a little bit about the supportive model, it is, it's grassroots, getting it. We have it, Optum has luckily partnered in 2 big markets, and it's in the schools, and it's with the Medicaid population, which is, public health. And the company has done on-the-ground, grassroots information. They set out tables outside of the schools. And what does everybody like? What's happening at this conference? How much food are we eating out there, okay? How many ice cream cones and petting the puppies? I mean, that's an amazing way to engage and get people interested. So what Supportive does is that any adolescent can go to this address, a web address, and then they're asked one question: what are you here for, or what's the problem you're coming to? I'm probably not reflecting. What's your struggle? Thank you, Steve. Okay, what's your struggle? And then through machine learning and educate, all of that they match you in, they put you immediately in a chat group. And what it is, a chat group with 4 to 8, or depending on how many, teens of the like mind, but it's in within minutes. And there is a older adolescent, a college student, or someone who's been trained as a moderator. And it's all chat. So it's anonymous. They don't have to use their voices, chat back and forth. And it's fascinating how much they get support from their other peers and the positive outcomes from that. And the return, those individuals that come back again for another problem. I can't sleep at night. I'm stressed about my exams. I'm breaking up with my boyfriend. They're not thinking about the big problems. This is what's important to them. And that's sort of the mismatch that I see, is that we as adults, or, sometimes I like to consider myself still an adolescent, we as adults tend to, the big problems, and you got to sit in therapy and all this. That does not match their developmental stage. And of course, they don't want to listen to us because we're parents. So it's a wonderful model. And actually, I would ask if, Helena can explain anything that I've misspoke about or that needs to be clarified about the model.
Yeah. Helena, do you want to take a stab at it?
I can only applaud Debbie's description of what we do. And I'll just say that, your question was about how do you match people at the right time. And I think that is a relevant question even for James and other service types. Because it's long been a big question. How do you match people? Anyone who has a provider network thinks about matching, members to the right provider. For us, we distilled it down to the topic that somebody wants to speak about at any given moment. So if we think about our lives, we all fit, a certain demographic here. And that demographic might be, I'm an executive with a work-related program and, performance reviews to deliver to my team tomorrow, and that's your concern du jour. But the next day you're a parent and you have a kid with ADHD and you need a peer who is a parent with that struggle. And the next day, maybe it is a, trigger into an old alcoholism issue that you have, and you need a peer who understands that. And then you need a peer who understands the caregiving that you're giving for your elderly in-laws. And so how do you think about peer through all those multidimensional lenses that represent who we are as people? And that's, one of the challenges of our industry and one of the things that we're trying to solve digitally.
Yeah, thanks for clarifying. It's really helpful.
If I could just add one
Yeah,
thing.
yeah.
The match for this app is what's your struggle. So if someone says stress at school, and immediately they will match them with anybody with a similar, and the chats just start. And it's amazing how many minutes the teenagers stay in the chat. They don't just stay 2 minutes, 30 minutes, 45 minutes. I mean, it's amazing. And I always want to tell people there are the safety off-ramps. That's always one of the biggest concerns, that it has a way, the moderators have a way of identifying those individuals at risk. And there's off-ramps and a way that we can engage them and get them the care that they need.
Yeah, Manny, I want to come to you. When we're talking about the potential, different types of behavioral health care and peer support that young adults and teens are looking for. Carolyn works with about 40 Fortune 500 clients. So I'm sort of curious, when we think about what potentially young people are wanting, and we think about more young people, Gen Z and Gen Alpha, getting into the workforce, how are you working with employers and incentivizing them that peer support is something that is worth it?
So they're looking for easy, right? I think in the world of Android and iPhones and everything else, we're being oftentimes kind of overwhelmed with all the different solution sets. And so there's a move to just making it easy and making it work. And so tying into just peer services broadly, there's also the dynamic, and especially for very large kind of national companies that we all maybe even have in our pockets or support us in one way or another, they are highly acute today, much more than ever before, around what is happening with the overall well-being and mental health of their workforce and of their families, right? I cannot be an effective employee if my child's life is a mess. I won't be. I know me, so I won't be. So then how does the employer support me and my family differently? And so with access being such an important topic across the country, having the appropriate opportunities, be it peer support, be it maybe some other self-help tools and content and information, maybe coaching, maybe something else. So it's really having that ecosystem all together to say, we're here to meet a need, not necessarily a condition or a session or over medicalize something, but we're here to meet a need, and large employers that really resonates with them.
Yeah, awesome. Thank you so much. And I want to bring up sort of something really critically important today, which is to name a few disparities when we think about behavioral health and mental health access. A recent Kaiser Family Foundation survey found that white adults are more likely to say they received mental health services in the past 3 years compared with Black and Hispanic adults, many of whom struggle to find culturally competent care, and that's just a couple of stats. So James, I'll come to you with this. Can you talk a little bit about how peer support can bridge these gaps and really engage people who have historically been left out of the healthcare system and also feel at larger distrust?
So no challenge there, huh? So there's a couple of things, and one is peers meet people where they are, right? You don't have to go into the office to see a peer, at least not with my program, and it sounds like with Supportive, they literally meet people where they are, which is online, right? And that's why I find that program so exciting, right? Because their pool for matching is so large, right? Anybody has access. That means anybody can match with anybody. My program is small. I only have a handful of peers, right? I asked for 200. They said no. There may be some issues with the number of actual peers available in the workforce. So what we do is we meet people where they are, and what that means is that we have the ability to reach the people that are unreachable, right? We can talk to somebody under a bridge. We can talk to somebody in the emergency room. We can talk to somebody when they're in a treatment center, when they're coming out of a treatment center, when they're incarcerated, coming out of incarceration. Wherever they happen to be, we can go there. And that means we have the ability to reach those folks that don't even know that they want help, right? We
Yeah.
don't make them, but we're there. And that gives us that opportunity. And that's the only way I know of to do it.
Can you share an example potentially for us about, you mentioned reaching the unreachable. Is there an example that resonates or comes to mind when you think of, a use case, right, of not just in the short term, but potentially a long-term outcome and benefit of reaching the unreachable?
Well, so I have a lot of success stories because my people are awesome. But I'll tell you a particular story. There was a young lady who was incarcerated. And we went to visit her in the facility where she was residing. And she wanted absolutely nothing to do with us at all. And we said, okay. And so the next time she was incarcerated, we went to visit her again. Wanted nothing to do with us. Next time she went into the jail, we went to visit her again. And the third time was like, you people are weird. Like, yes, thank you for noticing, we are. By the fifth time she was incarcerated, she was ready. She was ready to make a change. She is now a peer support specialist. The person who is unreachable, right? I'm going to cry. I mean, it's a huge victory for her and for the peer support program in general because now we have another peer, which we desperately need. And we were able to make that connection. And yes, it took us a few times. I have a lot of stories about the first time didn't work, the second time didn't work, the third time didn't work, the fifth time worked, the sixth time worked, right? Yeah.
Thank you so much for sharing
I can talk
that.
for hours.
Yeah. No, I think it's helpful to illustrate, an example of how this really looks and why it might be different from other models. Deborah, I wanted to come to you with this. When you started Supportive, you were really targeting teens, but now you've seen engagement with those older than 65. Sorry, Helena. I was wondering if you could talk a little bit about how you're engaging people intergenerationally in peer support, but also how you're thinking about age-specific circumstances as well.
Yes, for sure. So just like you said, so we've been around since 2018, and all told to date, we're coming around about 2 million unique individual users that we've served to date. And for the first year and a half that we were on the market, we exclusively went into school-based systems and drew in teens. Through a lot of outreach with, as Debbie Katz mentioned, these school-based systems, but also like social media, things like that. And it was actually kind of serendipitous growth because this is my second digital health company. In my previous, I had worked with large employers and health plans in the musculoskeletal health space. And so I was explaining to some of my old clients what I was doing these days, and one of them raised their hands and said, well, we want that for our employees. And it was Walmart. So Walmart became our first employer customer, and we soon found that we just took off. We just absolutely took off among their associate population, and the median age user was in their 50s, and it blew our minds. And then, conversations started to ensue with their group that really focused on Medicare populations because they saw this number, and that really expanded our mind. And we said, well, there's no reason why we couldn't do this for seniors. We'll offer some WCAG compliant interface on our same system and let it go. And then lo and behold, a couple years later, we had expanded into Medicare and now have just published a study on the impacts that we're seeing with a Medicare national plan impacting loneliness, where we're seeing decreases around 49% coming out of these conversations, and optimism increases of 37% coming out of these conversations. It is the same service. It is an identical service, but we have created filters to do cohort-based matching so that if it is an age or demographic or identity-based struggle that people are coming in with, we are ensuring that that millisecond of matching that happens to get them grouped with peers is specific to the demographic that they need.
Yeah. It's so important when we think about loneliness too affecting older adults, putting them at risk for a host of chronic conditions. And so that's awesome results. Deborah, I want to come to you a little bit to talk about, what does it really look like for an effective school-based peer support program? If you could talk about that a little bit.
Well, there are many different kinds of peer support programs. There are companies that are bringing peers directly in the school, physically recruiting older, like, say, 12th graders to help 9th graders. I mean, there are those kinds of programs. They're all different kinds of them. Again, using a smartphone, I mean, kids are on their phone. Let's just say kids. All of us are on our phones all the time, and I think it's a great tool to make those kind of connections. I think the big push is how you market it, how you get the message out. What we've noticed, and with the kind of work we were doing with supportive and word of mouth, okay? One teenager has a great experience, and they're, because they will go to their friends, they tell their friends, oh my God, I used this website, I got into a chat room. Well, we've seen an increase. Now, the engagement of the supportive staff has happened at the beginning and maybe some ongoing marketing. But it's all been word of mouth, because every month over month, they've seen 100% increase, 200% increase of engagement. And it's all because word of mouth. Teenagers talk to teenagers. They want to hear from each other. So, I mean, that's, so again, and their phones is the best conduit for them to be able to do that.
Yeah. Manny, is that what you're seeing as well, or how are you sort of also thinking about scaling some of these products, systems?
So the scaling question is a key opportunity, right? We know that peer support works from kind of what James was describing, a hand-to-hand combat, right? When you think about impacting one life, which is incredibly important and the right thing to do, but then how do you, to your point, how do you then take that further and broader? And so, we've tinkered with kind of telephonic peer support, right? So just having lines available and open to allow for, especially when there's like a moment in crisis. So kind of subclinical activity for like when there's a natural disaster, or there's, unfortunately, a mass shooting or something else, something that may occur, opening up some of those lines to allow for not just, a potential crisis intervention, but also just a peer engagement around that. But then even broader, it's how do you think about, folks like Supportive or others that may be using technology to really expand the scale of it so that you can get hundreds and thousands of individuals engaged and see that positive outcome to really drive, overall value and create additional access points within our system to get into some level of support.
Yeah, definitely. And I wanted to also bring up, given there's the scaling part of it when we think about these digital innovations and solutions, and I know, Deborah, you mentioned this at the top, but I want to maybe, talk about that more broadly. What are some of the necessary guardrails, safety supports out there so that people, say, are chatting with someone and it's not going well? What's out there, or that they're saying something very serious and danger and they're in a dire situation, and I know that different support systems work in different ways, right? I guess I'm more so thinking about it, online, but anyone can sort of jump into what are we thinking about when we're building these models and making sure we're protecting people, especially vulnerable youth.
So I might share. So James, why don't you talk about how you do it person to person, and then we can talk about digital. I mean, how do your peer support specialists handle situations like that?
Well, of course, it's as varied as the situations themselves, but one of the things that we try to do with our peers is whenever we can, we connect them with a clinician. So, for example, our justice program, which is our largest peer component, each peer is paired with a clinician. And so they're actually working together, doing slightly different functions around how to help this person transition out of an incarceration setting and back out into the world. And so they have that kind of safety net. The other piece is just a lot of training, right? We make sure that everybody is aware of what kind of the danger signs and symptoms are, right? And how to engage somebody and how to really have a conversation. Because the best way to disrupt trust is to call 911 when somebody's having a moment, right? I've done it. It works really, really well. But since disrupting trust is not actually our goal, we try to go at it a different way, right? We try to have a conversation with the person. And so we teach people about the conversation. And since our peers are used to having conversations with people even before they decide they want to be a peer support person, right? it works really, really well for them.
Yeah. Helena, did you want to add as well?
Yeah, so I mean, I'm glad you asked this because I think that one of the shocking moments for all of us during the pandemic, especially when so much of mental health went online, was how many of these like massive digital platforms were announcing in 2022, 2023, 2024 that they'd added crisis protection services to their existing platform. And it was like this, oh my God moment of like, how were they operating before? We thankfully thought about this, I will say, from the beginning. And, you know, we never had any intent of being a crisis service. One of the things that we do in our chats is make linkages and handoffs to services, whether they're, you know, community services or crisis services. We built in sort of, you know, pathways, if you will, to get people in crisis, whether it was suicide, active suicidality, or domestic violence or sexual assault. We want to get them to the experts. And so the first thing we did is that in each of our chats are always live moderated. So no chat, peer-to-peer, small group ever takes place without someone that we've trained facilitating and guiding that conversation in real time. Those folks go through extensive training that we'd established to be able to, you know, prove to us that they can detect those emerging crisis situations and enact protocol questions like, do you want to kill yourself today? You know, when they detect any sense of hopelessness or despair. Very quickly, because we actually are underpinned by a lot of sophisticated AI in the genre of natural language understanding, we built language models. And this is 2019, 2020, before these things were mainstream news, but we built language models around detection of hopelessness, of despair, of emerging danger situations, which we could then use to build in prompts into the system as that second layer of reminders for these humans who are actually doing those interventions. And based upon, you know, someone's answer to that questions, we have to make that split-second decision. Is this passive suicidality, for example, where someone is more than welcome to remain in the chat? I mean, that's really our bread and butter. We handle that day in and day out. Or is there a plan and intent, in which case we need to make that immediate handoff? And because we are a digital tool, that immediate handoff can happen, again, in milliseconds, right into the hands of a crisis-trained counselor. So we're building that into the platform from the ground up.
Thank you. Manny or Deborah, did you have anything you wanted to add on that?
I think it's been well stated, yeah.
Great. I wanted to ask you one more question, and then I'm going to go to the audience. So if you have anything, please feel free to put it in the QR code, or I can also just take questions on the spot. But I did want to ask Manny, and maybe someone else wants to jump in as well. You know, we're thinking about different models of peer support, and I think kind of distilling it as well for our audience, which is really helpful. What do you see as the next frontier in peer support?
All right.
Sorry.
So there has been, over the last probably 10 years, maybe 15, a real expansion of peer support in general, both from a managed care lens and health insurance lens, what is paid for, what isn't paid for, but also even how you think about peer support in not just, you know, from the advent of like AA and those kinds of things, but in oncology space, cardiac disease, you know, HIV/AIDS. There's been an expansion and a growth in it. And so I think part of that really translating even broader to the well-being space. And then tools like Supporter to be able to even match beyond just, you know, behavioral health, but behavioral health right? So thinking about a chronic condition, a comorbidity. So I'll give you a really quick example. So when at one point, I implemented and ran a Medicaid health plan for individuals living with serious mental illness. And we had our member call center, and then within our member call center, we had a separate call center that was a call center of peers. But a lot of what they were dealing with was, how do I check my diabetes? And these were not nurses or clinicians, they were peers. But they knew how to translate the questions and the information with support of a clinician, you know, either via IM or sitting right by them, that actually provided them the details on, how do I set up my DME equipment the right way? How do I set up, you know, fill in the blank. How do I take these insulin shots? Whatever it is, right? And it almost happened by like just happenstance. We didn't set the model up that way. It just happened because the need arose and people started answering, and we had staff that were peers that were really curious that would start Googling like, oh, what do you have? What device is it? What? And I was like, whoa, wait a minute. You're outside of the scope what you should be doing, was the initial reaction. Like, what are you doing well outside of scope? But then we started thinking, well, what would I do if I had a question and I couldn't get a clinician on the phone? I would call somebody to help me. And my brother, he's diabetic. Maybe call him and see if he knows how to do this, right? And so we reached out to a friend. And I think that is really part of the opportunity. So where do I see it going? I see it translating into much more broader and doubling down on total health and total well-being, with still an emphasis on behavioral health, but also all these other things that are impacting us and supporting it.
Go ahead.
I'd like to add a novel idea. I guess because I'm a child and adolescent psychiatrist and I look everything through a developmental lens, why aren't we starting early in kindergarten and elementary school, teaching our kids as part of how to empower yourself? We teach about bullying, we teach about the negative things. What about we teach about how to communicate and ask people around you and not have secrets, and give them the tools early on to rely on their peer group? Because we don't do any of that. I mean, all of us in this room have phoned a friend at some point in our lives, okay? Probably more often than not. So why don't we make it part of the culture from the start? We tend to be, you have to respect the diversity, but we are many times a culture of secrets. And if we normalize atypical behavior, I'm not going to call it dysfunctional, I'm going to let atypical, if we normalize it and give and teach the tools how to talk and to communicate with each other, it's a lifelong learning. We have neglected that. A lot of the work right now is about how do you empower little kids, starting in kindergarten, starting in nursery schools, how to have these tools to navigate the world. How do you problem solve? How do you talk to your friends? I see that's the next step, and it has to happen in families, in schools, in social organizations. It has to happen also. I think one of the best places for this to happen is on the ball field, in sports. I mean, it's the most beautiful, natural example of team and peers.
Yeah, what you said sort of goes into this question from the audience. I think kind of, more so thinking about anonymous peer support, less in person. But when we think about engaging people younger, they asked, anonymous peer support is gaining traction for people age 16 plus, but is struggling to take off for children because of fears over safety. So I think they're asking, how do we overcome this? Also thinking about what parents need to know about, the future of that as well. I don't know if anyone else wants to take that. You want to start?
I do think it's a challenge because a younger child, you have to get parental permission for them to be involved in anything, even in the school system. I mean, you can't get around that. And every state has its own age of consent. I think, again, if it becomes the DNA of the younger kids and you figure out a way, and also, why aren't schools and part of the PTAs and those organizations support the kids using these topics to train and educate parents about what's available, what's out there, instead of it being, don't talk to my kid about sex in school. Of course, I'm outing myself, okay? But really, why can't we give parents the tools and the permission to be able to talk about these things and let kids be, give permission. My fantasy, or not a fantasy, but I would always wish that when you go to school, and a special school, the parents that would be part of signing your kid into school, is going over the consents. They always do that for videotaping, or they do it for this. Why can't it be for this other stuff? And involving and communicating with parents. I think it's parents, guardians, caretakers have to be involved. It can't be in a secret silo. But at a certain age, someone can act for themselves.
Yeah. the model of the future, perhaps. We have time for maybe a couple quick questions. So I wanted to also, okay, great. Yeah, go ahead. If you don't mind coming up to the microphone, feel free to introduce yourself. A couple minutes left.
Hi, I'm Robert Accordino. I'm a child and adolescent psychiatrist like Deb. Is this on?
Yes.
Oh, it is on. Okay. And chief medical officer at Able2, which is now part of Optum. So I'm Deb's colleague at Optum. So just a comment. I thought this was really, this is the first that I'm learning about supportive, and congratulations on what you've built. It's really wonderful and such a ringing endorsement from the panel. One of the things that we don't think enough about that Deb's comments just triggered in terms of adolescent medicine, and just a shout out, there's this wonderful community center called the Mount Sinai Adolescent Health Center in New York. It's the largest freestanding center devoted to adolescent medicine in the country, and it's at this juncture of the richest and poorest zip codes. Upper East Side meets East Harlem. And adolescents choose to receive their care there because there is for the care, even when there's great resources to pay co-pays and so on and so forth, there's something that happens whenever a bill is sent home to teens. And there's a breaking of confidentiality in the billing codes of what parents receive. If you spend time to do, you're like, oh, my child just had all this testing for STIs. I wonder what was going on, based on the billing codes. So there's so much in terms of teen confidentiality that our system does not account for within the mainstream system that it's sort of relevant here, because when it's such a barrier to teens receiving physical or mental health care that we don't talk about enough, and there's sort of inherent problems in the way that we do business in terms of working with parents. So it's just a comment.
Thank you for that.
It really resonated what you were saying in terms of involvement of parents and appropriate permission.
Yeah.
So
Thank you. We have a couple minutes, so if you can make them quick.
So I'm Obi. I'm the founder of Flourish Labs, and we run peers.net, which is a one-on-one telehealth peer support service, and we train young adults to become peer supporters. So what we've noticed is that a lot of the teens don't necessarily want to do a pre-booked session, right? They like chat, like you were talking about the supportive, and we contract as a provider group, and so that breaks the model. Like in fee-for-service, it's very hard to charge for chat, but we don't also want to do a vendor contract. So what do we do?
Oh, I will tell you. One of the things, and I was wondering if it was going to come up, I work for a managed care company, and you have to change the mentality. It took us a lot of work to say to our hierarchy, if you're going to offer something like supportive in schools, you cannot just serve Optum patients. In fact, you want to be able to reach as many kids as possible, and you have to sell it like what you had said before, is that we're talking about these kids have parents who have jobs, and if the kid isn't doing well, it affects the productivity and their absenteeism, okay? You have to, that is the big, it's a leap of faith at first, but once you show them some of your outcomes and the feedback, you can get that buy-in. But it has to be, in a lot of ways, payer agnostic, because you're not going to go into a school, I refused, and say, oh, I'm sorry, this supportive is only for Optum members, okay? And that is a
Do
big
financial aid for those.
yeah, it's a big deal. And so I was in another listening earlier to a group, and you know what? Managed care companies have to stop the secret competition and get together and adopt these companies with payer agnostic, so that we can really reach more kids.
Thank you. One more quick question. I don't want to leave you hanging. There we go. We'll do it.
My name's Gabriella. Just a quick question. I'm excited to hear what your thoughts are on IOP or PHP as a solution, and maybe tailoring it for early children. To your point, Deborah, what do you guys think about that in-person care?
So I love IOP and PHP because that gives you an opportunity to immediately put into practice what you're learning, right? What you're experiencing in the therapeutic process. Peer support, IOP, right, is something that is not really a thing yet, but it would be cool. What was that? Okay, cool. It's not something that I'm familiar with. It's not something that... Right, yeah. So I mean, peers can integrate at any level, right?
Right, and IOP is group therapy, so there's a peer-to-peer component to it, right?
Right. Well, it certainly can be. Yeah. I mean, one of the things that we've done with psychosocial rehabilitation in the community mental health setting is having peers as a part of those groups, right, helping to co-facilitate those groups. In order for us to bill for it, right, we have to have a person who is certified to do that service, do the service, but empowering the members of the group to lead and run their own groups, right? And the best IOP sessions, the IOP facilitator is very, very quiet, right, and lets the group do their work.
Yeah. Well, thank you all so much for your thoughtful questions. Please come up after. Thank you. I'm sure people will talk more.